morning. Welcome everybody to my video lectures. Now 20% or 50% patients who have subarachnoid hemorrhage have abrupt onset, severe, minutes to hours long headaches, weeks or months before they hemorrhage. Though often overlooked, these warning or sentinel headaches require a same full and immediate diagnosis workup as the more full-blown symptoms and signs of subarachnoid hemorrhage. The same constellation of symptoms and signs suggestive of non-traumatic subarachnoid hemorrhage may denote an intracerebral hemorrhage. Hypertension is a critical disposing factor. Now, I come to the differential diagnosis and treatment of headache. Causes: subarachnoid hemorrhage, aneurysm, or arteriovenous malformations. Diagnosis by CT scan, then LP and CT. Does not show the hemorrhage and MHA of angiogram when indicated. Now, intracranial hemorrhage, aneurysm, arteriovenous malformations, and now we come to meningitis or encephalitis. This also can form into a structure causing causing headache. Now, cervical headache, history of past examination, and drug-related headache is from the history. And drug-related headache history is the diagnosis and the decortication of the offending drug. In addition to intracranial aneurysm and arteriovenous malformations, other vascular abnormalities, including amyloid angiopathy, cavernous angiomas, venous angiomas, dural vein thrombosis, and vasculitis, all increase the risk of intracerebral hemorrhage. Each of these has a distinctive time course, typical extent, prevalence, and risk of recurrence. Brain tumors and infarcts sometimes bleed. Cocaine and alcohol use may cause bleeding within the brain. Anticoagulants and antiplatelet agents promote the hemorrhage. In patients who may have intracranial hemorrhages, non-steroidal anti-inflammatory drugs must be avoided until the hemorrhage is ruled out. When the symptoms and signs suggestive of intracranial hemorrhage evolve gradually over hours or days and usually is associated with fever, then an infectious cause such as pyogenic meningitis, subdural hematoma, or viral encephalitis should be suspected. Severe headache and meningismus may come on very rapidly in cases of meningitis caused by the rupture of an abscess or tuberculoma, or when the infecting organism is Neisseria meningitis. When the meningismus is of acute onset, then spinal fluid must be examined immediately. In general, even if a bacterial cause is suspected, antibiotic treatment should be deferred until the spinal fluid is obtained for cell count and culture. If the meningococcal meningitis is strongly suspected because of an evolving ecchymotic rash and autonomic collapse or exposure to others proven or suspected to have this infection, then it may be appropriate to treat with antibiotics before spinal puncture. Whenever symptoms and signs suggest an intracranial mass or magnetic resonance imaging, this MRI should proceed with lumbar puncture unless the obtaining these neuro images would cause a potentially dangerous delay. The priority of CT or MRI versus lumbar puncture must be individualized. This much is for today. Next part of the video will come in the next video. Thank you.